So in our previous video, when we talked about myocardial infarctions, we talked about some complications like fibrous pericarditis, cardiac tamponade, Dressler syndrome. All right, these were all disorders of your pericardium. I think now we're gonna have a dedicated video just to explain some of them, okay? So this video is gonna be on pericardial diseases. Things wrong with your pericardium. What is your pericardium? It's a sac that surrounds your heart. So your heart has 3 layers. Your endocardium, your myocardium, and your epicardium. And it's surrounded by the sac, this fluid-filled sac. And your pericardium also has 3 layers. It's like everything has 3 layers, right? Your pericardium, your heart, your blood vessels, everything just seems to have 3 layers. So let's talk about the 3 layers. The first layer is actually a continuation of your epicardium. We call this your visceral pericardium. The outside layer is called your parietal pericardium, and your parietal pericardium is attached to this fibrinous layer called your fibrous pericardium. Those are the 3 layers of this fluid-filled sac that surrounds your heart. Visceral pericardium, visceral means related to the organ, that's why it's attached to the heart side. Parietal means attached to a wall. This is the one that is attached to your chest wall, the outside side. And your fibrous pericardium is called that because it's fibrous, okay? And then in between is fluid. And this is really, really good because it helps lubricate and helps your heart to expand and contract without causing, friction and all that stuff, right? Your heart can contract and expand and beat and all this stuff, and we don't really feel it. It doesn't rub against our chest wall. That'd be terrible. And it's due to this nice lubricating fluid, this nice lubricating sac we call the pericardium. That's your pericardium. Now, what can happen to your pericardium? We talked about a few. We talked about pericarditis. There were some causes like fibrinous pericarditis, like autoimmune Dressler pericarditis. Some other ones is coxsackie virus, especially coxsackie B. This virus loves your heart. It just loves your heart for whatever reason. And because of that, it can cause inflammation of your pericardium, pericarditis. Another one is uremia, which is seen in people with bad kidneys. You can't get rid of waste products, you get uremia. Uremia can inflame your pericardium, cause pericarditis, so renal chronic kidney disease. To talk about someone with chronic kidney disease develops pericarditis, uremia. So what are some signs? How do you know they have pericarditis? The most common complaint is sharp chest pain, worse on inspiration and lying down. Lying down. When you take a deep breath, air goes in, expands your lungs, blood goes back into your heart. That expands your heart. And so you have a lot of expansion, a lot of movement, and that can exacerbate pericarditis pain. Also lying down, when you're lying down, gravity pulls your chest wall down, limits the amount of space you can have that rub, you can have pericarditis pain. Easier when leaning forward, because for some reason you just physiologically have more space and you get relief. So all right, relief, leaning forward. Leaning forward. What will you hear when you auscultate the chest on physical exam? You hear a friction rub. Usually we don't have friction, we have a nice pericardium with fluid, but if it's inflamed, then that could certainly change. So you have a friction rub, you'll hear a little rubbing, okay? Friction rub. What do you see on ECG? We said that ST elevations are seen in transmural insults and pericarditis and pericardial disease. Well, gave it away. You see ST elevations. Diffuse ST elevations, all leads because it's affecting every part of your heart. That is what you see. Now let's say someone has pericarditis, you see a ton of fluid and you sample and it's bloody. If it's bloody, you're thinking of causes like cancer and TB. Right, that is not normal. All right, the most common causes are viral, they usually go away, but if you see blood You just gotta investigate it further. That's pericarditis. Another pericardial disease we talked about was cardiac tamponade. Cardiac tamponade. This is when there's a rupture in your heart wall and blood will leak into this space, your pericardial space. So here's your heart, surrounded by a sac. If blood leaks in and fills this full of blood, it will compress your heart. Compress your heart. Make it really, really difficult to expand. It's like compressing it, squishing it in. Difficult to expand, so I'll just write difficult to expand. Difficult to fill is probably a better way to word it. Difficult to fill, all right? So you have your right atria, right ventricle, left atria, left ventricle. So your superior and your inferior vena cava is right here. Now it's surrounded by your pericardium and it's compressing in. So it's pressing in and squishing it. Blood is very difficult for blood to enter because it's getting squished, and so blood remains. So you get things like distended neck veins, you get distant heart sounds. You have a layer of fluid around it and also can't beat as hard because it's basically getting smushed, so you get distant heart sounds. And you get hypotension. If you can't fill it with blood, then you don't really pump any blood out, right? You don't get blood into your vessels, you get decreased blood pressure, you get decreased cardiac output. And then the last physical exam finding that you should know is Pulsus Paradoxus. What the heck is Pulsus Paradoxus? Pulsus Paradoxus is when you take a deep breath and your blood pressure drops. Why does your blood pressure drop when you take a deep breath? Well, let's pretend you don't have cardiac tamponade. Let's just pretend you have a normal heart, normal pericardium. When you take a deep breath, air goes into your lungs, blood goes into your heart. Blood goes into your heart, goes into your right atria and your right ventricle. Your right ventricle will fill and kind of bulge a little, right? And when it bulges, you reduce the amount of blood that can fill into your left ventricle. You reduce the amount of blood that can get pumped out. You reduce cardiac output. You reduce your blood pressure on inspiration. That is normal. However, the drop is very minute, less than 10. Our body minimizes it because our left ventricle is bigger, it's stronger. It has to push blood to our tip of our fingers, tip of our toes. So it's bigger and stronger. And during contraction, during systole, it will push back, reduce that, right? And also during diastole, when it relaxes, it again will push back, reduces that kind of bulge, right? So the drop is very small. In cardiac tamponade, however, when you have a bunch of blood pushing all over, then it equalizes diastolic pressure. It equalizes how much your left ventricle can relax and push back. It equalizes how much your left ventricle can contract and push back. And so it can't really push back anymore, right? That bulge is going to stay there. And if it stays there, then you can't pump as much blood during systole when you're taking a deep breath. That is called Pulsus Paradoxus. So when you take a deep breath, blood fills in, pushes this out, pushes your left ventricle. You can't really pump as much blood. Blood pressure drops by more than 10 points on inspiration. That is Pulsus Paradoxus. And it's seen in cardiac tamponade. It's also seen in other things. It's seen in lung pathologies. If you remember, we said that your right heart pumps blood to your lungs. That returns to your left heart pumps it out to your body, right? In lung pathologies, if your lungs are damaged, your right heart will strain to push blood into these damaged lungs, and your right ventricle will get larger and larger and stronger, and will now mirror your left ventricle. And so your left ventricle can't push back anymore. Yeah, we said that your left ventricle usually could push back. Well, it can't push back anymore. Your right ventricle is now as strong as it is. So Pulsus Paradoxus is also seen in lung pathologies, like asthma, like obstructive lung diseases. Okay, that is Pulsus Paradoxus. That is all I want to talk about the pericardium. Done with that. Now we're going to switch gears completely, and we're going to talk about cardiomyopathies. Why I put these two together, I have no clue, but that's the way it is. Cardiomyopathies. Cardiomyopathies. This is pathology dealing with the heart muscles. Cardiomyopathy. Just something to keep in mind before we talk about cardiomyopathies. Your heart cells have the contractile sarcomeres, right? And if it needs more, it can recruit more. It can recruit more in parallel. We call this eccentric hypertrophy. And this kind of thins it out. Kind of thins out the muscle, yeah? Or you can recruit it in series. And this thickens. This thickens it. We call this concentric. Concentric means with a center. You know, they share a center, and you kind of build these in series. Eccentric means there isn't a center. There's no center. You just kind of put them in parallel. So just keep that in mind. The first cardiomyopathy we're going to talk about is dilated cardiomyopathy. Here there's some sort of insult, some sort of damage to your heart, and it responds. It responds by eccentric hypertrophy. And that will thin your heart out and dilate it. So pretend this was your normal heart. Right atria, left atria, right ventricle, left ventricle. For some sort of insult, you start recruiting sarcomeres in a parallel fashion, and now it will thin it out and dilate it. So right, thin out and dilate. And when you thin it out and dilate it and expand it, then it loses its ability to contract, right? It's kind of like stretching out a rubber band. You stretch it enough, it doesn't really spring back as well. So it loses its ability to contract. Can't contract. We call that systolic dysfunction. Systole is when you contract. So if you can't contract, we call that systolic dysfunction. I'll put a star on it. Put a star on it. They like to ask that. Now, what can cause this dilated cardiomyopathies? Well, coxsackie, B, we said that was a virus that loads your heart, damages your heart, causes it. Alcohol is a direct toxin. That's probably the most common cause that you should know. You can have drugs, you can have thiamine deficiency, you can have chemo drugs like doxorubicin. Postpartum, so a pregnant lady gave birth, they're having this cardiomyopathy, they're having this dilated heart. What happened? It's just postpartum, yeah? In pregnant ladies, you have more blood volume because you have to supply your baby. So increased preload, increased stretch, increased filling. Also hypertension is common. So all these things can lead to postpartum dilated cardiomyopathies. These are common causes that you should know. Now on chest x-ray, it'll show a large heart. Physical exam findings. Well, fluid will fill up your heart. You'll have fluid overload. Does fluid overload make a sound on chest auscultation? Can you remind me if it does? Yes, it makes an S3 heart sound. S3 heart sound we said due to fluid overload. Okay? So it fills it up, causes that S3, and then it can't really contract. It can't really pump that blood out. And not only can it not pump that blood out, but when you contract, you close your valves, remember? You have your little chordae tendinite that close your valves. If you can't close these valves, then blood will pump through and cause a regurg murmur. These are all things that can be heard on auscultation of a dilated cardiomyopathy. That is dilated cardiomyopathy. The second one is hypertrophic. Judging by the name, you have hypertrophy. Is it going to be eccentric or is it going to be concentric? It's going to be concentric. And by making it concentric, you thicken the heart. So you make the walls really, 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 really thick. Okay, so very thicken, stiff walls. About 90% of it is due to an autosomal dominant mutation in beta-myosin heavy chain. And you might say, well, in people that exercise, don't they also have kind of a hypertrophy wall, a thickened wall, and that kind of helps their heart pump? Well, this is not a normal process, right? If you actually biopsy, then you'll see that the cells are in disarray. So myocytes in disarray. This thickened heart demands more oxygen, all right? And if it doesn't get enough oxygen, it can have an arrhythmia. Myocytes that were already in disarray have an arrhythmia. So arrhythmias are very common causes of death. To talk about a young person, usually an athlete, they're working out, they need more oxygen in their heart because they're working out, and then all of a sudden, because of the lack of oxygen, because of the myocyte disarray, they throw an arrhythmia and they die on the field. So that's the most common cause of death in young athletes. That's a really sad story that you read on your newspaper, like a 18-year-old playing football, drops dead on the field, hypertrophic cardiomyopathy. Okay, hypertrophic cardiomyopathy. What will you find on physical exam findings? Well, in a thickened, stiff heart, does that make a noise on auscultation? Does it? Yeah. S4, remember S4 was thickened, stiff ventricles, okay? And it will also make a hypertrophic cardiomyopathy murmur. It's very unique to it, and we'll talk about murmurs when we talk about our murmur videos, but just know there's another murmur and the S4. How do you treat it? You can stop sports, tell them not to do sports because that increases oxygen demand. You have beta blockers, which reduces your heart rate, reduces your contractility, reduces your oxygen demand. And if they're at really high risk, put a defibrillator in them. So if they do throw an arrhythmia, they can defib. What do you think they call a defibrillator? Last but not least, we have restrictive/infiltrative cardiomyopathy. Infiltrative. All right. This is when things either deposit in your heart and stiffen your wall, or you have some sort of fibrosis that deposits in your heart and stiffens your wall. So deposition of things include things like amyloidosis, where amyloid deposits, things like hemochromatosis. Pause the video. Tell me everything you know about hemochromatosis, down to the gene it's implicated in. All right, if you're able to do that, you're in great shape. You can have infiltrates like sarcoidosis. Pause the video. Tell me everything you know about sarcoidosis. All right, everything you know about sarcoidosis. One of the most common things you should say is that it causes non-caseating granulomas, and those are the granulomas that you see in your heart that cause thickening, stiffening of your vessels, of your heart, causing cardiomyopathy. So sarcoidosis, you get something called Loeffler. Loeffler is eosinophils that go into the lungs, but it can also go into your heart. So you biopsy it, you see a ton of eosinophils. It's Loeffler's. And then just plain fibrosis that thickens the heart. One common way I like to ask is radiation. So someone had a cancer, they underwent radiation, and then now they're having heart problem, restrictive cardiomyopathy. Okay. If you have a stiff heart, can that fill with blood? No. So restrictive is a diastolic dysfunction. Diastolic dysfunction. And diastole, your heart relaxes and should fill with blood. If you can't do that, diastolic dysfunction. Hypertrophic cardiomyopathy, thickened heart, can't relax, can't fill with blood, diastolic dysfunction. So that is cardiomyopathies, that is pericardial diseases. Hope you enjoyed. Thanks.